Hello, everybody. Welcome. I will give folks about 30 more seconds to come in, get hooked up to audio. In the meantime, welcome to the Congenital Syphilis Learning Series, Part 2. Okay.
Just let me know when I should get started.
Yeah. Thank you all for joining. For the sake of time, I am going to get started. And with that, let's pass it off to Martha from Migrant Clinicians Network.
Thanks, Jing. Welcome everyone to the second session of our series on congenital syphilis. My name is Martha Alvarado. I am the manager of online education with Migrant Clinicians Network. We have partnered with Health Outreach Partners and the Washington State Department of Health for today's presentation. Let's go to the next slide, please. As a reminder, this session is being simultaneously interpreted into Spanish. To listen to the Spanish interpretation, locate the globe-shaped icon at the bottom of your screen within the Zoom toolbar. Click on it, a menu will appear, and you can select Spanish from that menu. Next slide. You can also view the Spanish language slides by clicking on the tab at the top of your screen labeled Español. If you are using the older version of Zoom, there is a View Options tab at the top of your screen. Click on the tab. A drop-down menu will appear, and you can select Español. Next slide. Continuing nursing and medical education will be provided for this session. Migrant Clinicians Network is an accredited provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. Migrant Clinicians Network has also applied to the American Academy of Family Physicians, for continuing medical education, and determination is still pending. Next slide. To comply with the accrediting body's requirements, I'm going to go ahead and read the disclosure statement. We have no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. This presentation was supported by a federal grant from HRSA. No relevant financial relationships were identified for any individuals with the ability to control content of the activity. With that, I'm going to go ahead and hand it over to my colleague from Health Outreach Partners, Jing, who will present today's speakers. Jing?
Good morning, good afternoon to everybody, depending on where you may be calling in. My name is Jing. I am with Health Outreach Partners. I am joined here by Cindy Selmy, my colleague. We are also in collaboration with Renee Edwards at Migrant Clinicians Network and Martha Alvarado as well. Today, this session will be facilitated by our incomparable speakers. First, we have Benjamin Mayana. He has worked in public health for over 8 years within community-based organizations, local health departments, and is currently with the Washington State Department of Health as a sexual health coordinator for vaccine preventable conditions that can be transmitted sexually. Most of his public health career has been in HIV and sexually transmitted infection prevention, but he also has experience with emerging conditions such as coronavirus and Mpox and immunization programs. He obtained his Master's of Science in Epidemiology at the University of Washington in 2024 to further his public health career. In addition to Ben, we are joined by Victor Ruiz. Victor was born in Gilroy, California, and spent most of his life in the central region of Washington State. He identifies as Latin American and Native American of the Yakima tribe. He graduated from Central Washington University with a Bachelor's of Art in Law and Justice, specializing in legal studies and sociology. He started his career in public health in HIV and sexually transmitted infections prevention, connecting people to testing. He felt confident that public health was the career path that he wanted to take. And so he started working as a field services consultant with the Washington State Department of Health in 2018. Through his experience as a disease intervention specialist, Victor currently supervises the Care Connection team, a team of people who help pregnant people, people living with HIV, and people with hepatitis C connect and engage with care in rural communities in central Washington state. Next slide. Today, we are covering congenital syphilis as it relates to testing, staging, and treatment, and we will go over the importance of working with partners. Next slide. Our objectives today are to be able to summarize the variation in local testing algorithms for pregnant people and current syphilis treatment guidelines, discuss the purpose and value of coordinating with local health departments for partner services and completion of syphilis treatment, and discuss whole person factors that impact reinfection and the effort required for a patient to access care from a provider. Today's agenda, we will be going over the syphilis basics, that is testing, staging, and treatment. We will also review strategies to reduce transmission. With that being said, I'm going to hand it over to our speaker, Ben.
Thanks so much, Jing. Good morning, good afternoon, everybody. So kind of jumping off from our last session, just kind of a reminder of what syphilis is. So syphilis is a sexually transmitted infection, and the agent is a bacteria. It's transmitted through skin-to-skin contact, with a person who is actively showing symptoms, and spread through vaginal, anal, or oral sex. So again, this is not something that you can get casually from, touching objects, doorknobs, toilet seats, pools, hot tubs, as I feel like is kind of the misinformation around certain sexually transmitted infections. What makes syphilis kind of confusing is that as the duration of the infection continues, it goes through different stages where it has certain symptoms, and then also where it goes through periods where someone has no symptoms. And so this has caused syphilis to be called the Great Pretender, as it can kind of mimic other kind of conditions, infections, and diseases. Um, and so we're going to be kind of jumping into it because different stages have different treatments, they have different symptoms, and it's confusing, but hopefully it'll be a little less confusing after today. Next slide, please. So the first thing is, okay, so how does someone actually come to find out that they have syphilis? And that's through different tests that are conducted through blood draws. There are rapid syphilis tests that are done through a finger prick, but it is not enough to diagnose someone with a syphilis infection. For that, they do need to conduct kind of a blood draw. So if you see on the slide, there are different kind of testing flows for how we can actually figure out if someone has a syphilis infection. One of the main tests is a rapid plasma reagent test. In English, the letters are frequently RPR. This test is a quantitative test and is used by diluting someone's blood until they can no longer detect the presence of syphilis. This is really important as this is used to determine if someone has a older infection versus a newer infection. Other tests included are kind of immune tests or tests that look for the body's immune response to the syphilis bacterium. These two tests are known as enzyme immunoassays and also treponemal pallidum antibody particle agglutination. Super complicated. Mostly they're used in kind of their letter abbreviations in English, EIA and TPPA. Really, the main takeaway from here for non-clinicians is that there are many, all this is being done to determine if someone has syphilis. So if you have a patient that kind of says, "Oh, I don't think I have it. I think it's a false positive." Nah, we did all this. You probably do have a syphilis infection, because it's been confirmed through different series of tests. Um, Next slide. Another thing too is really important when talking about testing is a testing history. So as I mentioned, some of these tests, a patient, if they ever had a syphilis infection, will continue to test positive. So we need to know if that person has had a history of syphilis so we can compare the results of old tests. So that uh, RPR test, um, we compare the different titers or dilutions, to observe if someone has a new syphilis infection or not. Um, because of this, and because we work with many patients who um, migrate from different states, sometimes along state borders. They move from health systems because of changes to insurance coverage. It can be really difficult to kind of understand what a patient's test result actually means without that historical context. Um, so again, this is just kind of to plug that your local and or state health departments can help you interpret your patient's test result and if this is a new infection or if this patient needs treatment or not. Every state health department has one designated person who can get records from other states. So again, really important. Uh, Work with your health departments. That's my first plug with that. Next slide, please. So okay, someone becomes infected with the syphilis bacteria, which is called Treponema pallidum. Um, as the disease progresses through time, someone can go through different stages. As you can see in this infographic, from initial infection, someone progresses to primary syphilis. Then, if they go untreated, they could progress to secondary syphilis. Sometimes between those two stages, there's a latent stage, meaning someone may have their symptoms may resolve, but they still have the infection. Then, after secondary syphilis, they go through another latency stage, where it can progress to tertiary syphilis. Um, Before in the past, um, there was kind of the connotation or impression that neurosyphilis or the neurological symptoms that a syphilis infection could cause occurred really late in someone's infection. Um, but that is now not true. We are observing that neurosyphilis or those neurological symptoms can occur at any stage. And that's not to fearmonger, but it's more just to empower people in their decision-making processes and kind of your communication with patients. Um, if a pregnant person has syphilis throughout any of these stages, more so if the pregnant person has earlier syphilis, so primary or secondary, they can transmit syphilis to their child, and that is called congenital syphilis. So this is kind of a broad overview. And then on the next slide, we'll kind of dive more into each stage and what that kind of means. So, the next couple slides, not really my style of presentation, but there's going to be a lot of content on them. I just mostly want folks to have this as a reference. But so don't be overwhelmed by a lot of the words that are on these slides. Um, you will also see in these slides a couple of QR codes that you can scan to observe images of some of the symptoms that I'm going to be describing. Because of the um, because syphilis is a sexually transmitted infection, you may see images of genitalia, and I do want to warn you before scanning. But that's my little disclaimer. So the first stage in syphilis is primary syphilis. And usually this manifests as a sore that can appear on the penis, on the vagina, on the anus, or the rectum. It can also occur in the mouth, so the lips and on the tongue and in the mouth. Um, while they kind of look like painful, when you see these images, they're actually not pain. They don't cause any pain, which is kind of why it could be transmitted so often because a lot of people often don't realize that they have these sores, especially if you have it in your rectum or inside the vagina, where people may not be observing in those areas often. These symptoms can last about 1 to 5 weeks, and on average about 3 weeks. Um, again, from you are quite contagious during this stage, and these symptoms could pop up from 10 to 90 days after you were first infected. So again, about like up to 3 months. Um, and so, and again, you need to be treated at this stage um, in order to be considered cured and not transmitted to anybody. Next slide, please. Okay, so let's say after your primary stage, your symptoms go away. Then after maybe about 6 months after you were first infected on average, you then may develop something called secondary syphilis. Um, Now, secondary syphilis looks a little different from primary syphilis from that sore. It could appear as a rash on the body, very kind of like the typical rash is on the hands and on the bottoms of the feet, but that rash can also appear kind of on the trunk as well. Sometimes it can cause additional sores that look different from the primary syphilis sore, and that can appear on the mouth, vagina, anus, again, anywhere where someone is having that sexual contact. It can also cause fever, swollen lymph nodes, sore throat, patchy hair loss, headaches, weight loss, muscle aches, or fatigue. Again, this is such a generalized kind of list of symptoms that if you're not that familiar with seeing this, you see a rash, maybe you think it's contact dermatitis, maybe you think it's herpes. It's the great pretender. A lot of these symptoms could be something else. Um, so my shtick is make sure you keep syphilis on differential diagnoses, especially if someone is pregnant. And again, these symptoms can last 2 to 6 weeks, and then they kind of go away. Um, Next slide, please. So the latent stages. So latent syphilis means that someone does not have syphilis, the symptoms of syphilis. And so from that primary to secondary, sometimes people don't have symptoms, and that's called early latent syphilis. Um, and then, after that secondary list of symptoms, people can go to late latent. Um, Again, typically there's no symptoms during this time. And to be able to kind of understand, you know, what your patient has when they have no symptoms, to kind of work with your local health department because it is confusing. And it's important because the treatment for these two periods of no symptoms are different. And if someone does not receive adequate treatment, it could cause complications like congenital syphilis or the syphilis that occurs in unborn children. So again, kind of again confusing, but wanted to plug this is why we're kind of going into nitty-gritty detail because the treatment does differ and it's depending on when someone is infected. Next slide, please. So tertiary syphilis is, again, if someone has gone untreated for syphilis for quite a long time. This is pretty rare in modern day United States. But again, it could still occur. And this is more kind of severe symptoms, such as it's a gummatous lesion or it's a very specific kind of rash. It can cause heart problems. It can cause a lot of neurological issues. So it can cause like dementia-like symptoms as it enters into, as the syphilis bacteria enters the neurological system. It could cause issues with your vision and your hearing. And again, it's quite rare now because we do detect cases of syphilis earlier on, but this is still a possibility that can occur when someone goes untreated. Next slide, please. So as I mentioned, throughout any time in someone's infection with syphilis, they could develop neurological issues. Some of these issues, again, depends on where the bacteria kind of goes into. So if it goes into any sort of like the um, auditory system, it can cause issues with hearing, with balance. It can cause issues with like headache and fatigue. If it enters like the ocular or the eye system, it can cause issues with vision. Sometimes people have floaters, and it can also cause swollen eyes. Um, if you suspect that a patient has any sort of neurological symptom with syphilis, um, and you don't have a good referral, um, to an infectious disease provider to be able to rule out these issues, please again work with your local health department. Sometimes they would be able to help provide a referral. Next slide, please. Okay, so we kind of walk through each stage, and so how do we stop it? How do we actually treat someone's syphilis infection? Um, so for kind of the earlier syphilis stages. So this is primary, secondary, and early latent. When someone is has no symptoms in between the first and the second stage. Um, it could be a single dose of penicillin administered in either one or two shots. Or it can also be 14 days of 100 milligrams of doxycycline taken two times per day. Um, and again, for pregnant people, they cannot receive doxycycline. Um, and so they must receive penicillin or bicillin. Um, if someone, again, is late latent, so after they've had those symptoms, they need to have 3 doses of penicillin administered 1 week apart. This is pretty complicated, in terms of trying to get someone scheduled. If they miss any of those doses, they have to restart in order to be properly treated. Also, if we can't determine when someone received their infection, we have to be super cautious and we have to treat them for late lay-in. Um, and again, if someone is not pregnant, they could also receive 28 days of doxycycline, um, again, with the same dosage. But again, that's also difficult for some people to take a pill every day for about a month if they're not used to taking that. So it's kind of weighing the cost benefit of treatment options for certain people. Um, and again, if someone is allergic to penicillin, um, that they can be desensitized. and then ultimately treated with penicillin. So especially for pregnant individuals, if there is a penicillin allergy um, it, observed in their history, that they kind of need to go admitted into a hospital and undergo that desensitization in order to be properly treated. Next slide, please. So, congenital syphilis is when syphilis is transmitted during pregnancy to the fetus. And again, this can occur at any stage, um, but the risk of transmission is higher in those earlier stages, so primary, secondary. Um, the Congenital syphilis can cause a variety of symptoms, but it can cause infant death, it can cause stillbirth, it can cause an infant to have clinical signs and symptoms of syphilis. And it can also result in permanent skeletal issues as well. Um, all infants who test positive for syphilis or who are at risk for congenital syphilis should um, kind of go through these examinations at delivery in the hospital. And again, because syphilis has to be complicated. There's also different stages of congenital syphilis as well that we're going to go into. Next slide, please. So, early congenital syphilis is when the child has symptoms infancy to 2 years of age. Some of the more common symptoms are, you know, nasal discharge, enlarged liver and spleen, jaundice, bone abnormalities, skin rash, some eye conditions, swollen lymph nodes, anemia, and other blood abnormalities, and neurologic issues. Again, some of these symptoms are evaluated at delivery based on whether or not the pregnant person um, was adequately treated before delivery. Next slide. If the child does not receive any treatment and they continue to have their syphilis infection, um, they can sometimes have late congenital syphilis, which can cause kind of some of these more severe and kind of scarier sounding symptoms, such as, facial changes, um, abnormalities in tooth development, bone abnormalities, and then some of these neurologic conditions, such as, issues with the eyes and issues with hearing. So this is something that we want to prevent. It could be kind of scary. Um, and so let's talk about how we can kind of um, treat our congenital cases to kind of prevent some of these serious outcomes. Next slide, please. Again, treatment for the child is dependent on whether the mother was adequately treated during pregnancy. Depends on what signs or symptoms the child has, what the mother's test results are for syphilis at delivery, and also the child's test results as well. Based off a combination of all those kind of data points or data sources, there are four possible scenarios um, that a child would be treated and made sure to prevent um, any of some of those severe symptoms. So again, on the next slide, we'll kind of get into some of those scenarios. So, if a child is born and they appear to have signs and symptoms of congenital syphilis, they have a really high titer than their mother at delivery. Um, and especially if the mother was not treated throughout pregnancy. Um, and upon evaluation, um, they have um, a positive cerebral spinal fluid, um, or a high cell count or protein count in their cerebral spinal fluid. Um, then this is probably a confirmed case of congenital syphilis. Um, and the recommended treatment is intravenous penicillin G administered every 12 hours during the first 7 days of life and every 8 hours thereafter for a total of 10 days, or a single penicillin intramuscular dose daily for 10 days. Um, and again, so these slides are kind of organized by, um, more for like a clinician, and kind of the recommended evaluation if you have a patient that meets these criteria and kind of the recommended treatment. And this is all coming from CDC, the Centers for Disease Control and Detection, standards for treating congenital syphilis. Um, Next slide. Again, more here for you all to reference, but more just the what happens to a baby and kind of the work that needs to be done in order to prevent some of those serious outcomes. So for possible congenital syphilis, it's, the baby appears to be okay. Um, and they do have a positive syphilis test, but the mother was not adequately treated, or there wasn't documented that she was treated properly. Treatment was started less than 30 days before delivery, or mother had a treatment failure of some sort. Um, so again, because of the possibility that, okay, maybe this baby doesn't have the signs or symptoms, um, but we should kind of do some additional evaluation, and also to be safe, kind of do the same regimen as that kind of confirmed scenario. So either intravenous antibiotics, intravenous penicillin, um, a single dose of penicillin administered daily for 10 days, or just a single dose. Again, depending on what you as a provider kind of evaluate and determine for the child. Next slide, please. Okay, so let's say, the baby looks okay after birth. They did have a positive test, but it's less than the mother's at delivery, the titer. Um, and the mother was appropriately treated, and there was no evidence of reinfection or a relapse at all on the mother's end during pregnancy. It's, just out of caution, the recommended treatment would be a single dose of penicillin for the baby. Next slide, please. And then, if this is kind of like the unlikely scenario that the baby does have congenital syphilis, if, upon examination, they look okay, they do have a positive syphilis test, but the titer is less than the mother's. The mother was adequately treated, and the mother's titer was low and stable throughout the pregnancy. Again, no evaluation is recommended, no treatment is required, but providers could consider, out of caution, again, doing one dose of penicillin. Next slide, please. So this was a lot. I fully recognize the nuances of treatment, of how do I know where someone has it, what stage are they in, is this appropriate treatment? I just need to externally process with someone because this is maybe the first case of syphilis I'm working on, or treating. There is a lot of support available. One, your local or state health department could kind of help walk through, and offer different recommendations. Um, Two, there is a clinician consultation service offered by the National Network of STD Clinical Prevention Training Centers. Um, and so that is linked there. Again, a really great resource that you can connect with another clinician and kind of have that kind of dialogue. It's not immediate. It's usually a couple days. I think within 2 days, you'll get a response. Um, and, let's say too that if your patient is moving, which happens a lot with some of our pregnant people who are moving different states, be sure to also sign up to use Health Network and arrange for services in the new location worldwide. Um, and so you can also transfer their medical records as well. It's also really nice. I've always appreciated receiving calls from other health departments, just giving a heads up saying, hey, this person started their treatment. They need their treatment because they're on vacation or they're moving. Can you help them out? And so it's that's a really cool service that is available. Okay, I've talked for a really long time. I think it's time to hear kind of how these different things happen within the field. So I'm going to pass it on over to Victor.
Good morning and good afternoon, everyone. My name is Victor Reese. I work for the Washington State Department of Health. I am the Care Connector Coordinator. My team works primarily with syphilis and pregnant people, people who are out of care or need follow-up for people living with HIV, and we work and engage folks who test positive for Hep C and try to engage hepatitis C and engage them into care. If we mind going to the next slide. We're going to discuss a few stories today. I do have two on this slide and the next slide, and another one coming up. The first story I do want to discuss is we had this client who delivered their child at home. She had reported going to the hospital after having concerns of her baby having complications of breathing. And this is where there's some tests were ran, and they had found out that the baby had tested positive for syphilis. They had asked the pregnant person if they were in any prenatal care, and their answer was no. They do have history of using substance use disorder. And during this hospital visit, the mother of the child was also tested for syphilis, and she did come back positive. Uh, she reported not to have any signs or symptoms. Initially, we thought that she was a latent stage and needed to be treated for the adequate treatment for latent stage of syphilis. Upon interviewing her, she did discuss having one sexual partner who identified as male, who we connected to testing and treatment at the local health department. It was then that we discovered that he actually did have a chancre on his penis and was evaluated and was staged from the health department as primary. Because of her stage, her partner's stage and diagnosis, she would be considered early latent and not late latent, which means that she would need a different type of treatment regimen. Because she was early latent, she would need the one dose of Bicillin, 2.4 milliunits. Baby, again, was tested and came back positive due to having no signs or symptoms and a mother not being treated before delivery. The provider conducted additional evaluation and had resulted in elevated cerebral spinal fluid, also known as CSF, proteins. Provider decided to treat baby with IV penicillin for 10 days. And when having conversations with the provider and looking at which scenario that this baby would fit under, and it would actually fit under scenario two, uh, based on let me go back to scenario two. Based on mother, having normal examinations due to no signs or symptoms. However, mother was not treated and had no documents of receiving adequate treatment. So in this case, for the baby did receive the IV penicillin for 10 days. Next slide, please. Thank you. Stories from the field. So as I'm gonna go into another story, but a lot of these cases that we do take on are complicated cases. And this is common working with syphilis because, again, like Ben said, syphilis is one of those tricky infections that can play off as being another infection, but the only way to know that one individual has syphilis is if they get tested with a blood draw. It is vital to work with healthcare providers with the health departments to get the person treated. Um, so this next story I wanted to discuss was we had a pregnant person who moved to Washington State for work, and then she was filing paperwork uh, through the refugee program, and went in and discovered that she was actually pregnant and had tested positive for syphilis. Upon receiving the case report, we began to immediately investigate and reach out to the patient. The patient had mentioned that she had tested positive for syphilis and was treated in Mexico, but unfortunately had no documentation, uh, any documentation in any of her labs or treatment. And with this, we did let her know because she did have the antibody test reactive and the RPR did react to an RPR level that with no documentation to adequately to determine she was adequately treated, we recommend that we would be able to work with her on getting her treated with the ordering provider. There was one challenge though with the ordering provider. They unfortunately did not have the Bicillin treatment on hand. So we did work with the client provider and the local health department to get her treated at the health department. Uh, and at this point, because there's no documentation, the patient had no signs or symptoms. We went ahead and worked with the provider to staged as a latent stage of syphilis. One barrier that she did have, what for her was language barrier, um, and transportation. With the language barrier, the client was confused of why she needed to be retreated, what was going on. And luckily with our staff, we were able to communicate that with her and really go thoroughly into her about what syphilis is, ways of transmission, and treatment and how to help advocate for herself to let her any provider she goes in the future know that she has had a history of syphilis and this is the she's receiving adequate treatment with the local health department. She did have barriers of transportation going to and from the health department. So with my team, uh, we were able to pick her up and transport her to the health department to ensure she receives adequate treatment and work with the health department to provide that information to her OBGYN. So that way we're all communicating amongst the health department, her her prenatal care, and as well with her to ensure that she stays into care. This is very important because if we're able to work among providers, the health department, and the individuals, and to ensure that they receive care and stay in care, we are then preventing a case definition of congenital syphilis. Next slide, please. All right, I'm going to go ahead and hand it over back to Ben. Thank you.
Thanks, Victor. And yeah, I always appreciate hearing those stories because it provides context to a lot of this kind of like learning and knowledge and more just the real world implications of how some of these things can interact. So I appreciate your stories and your perspective. Um, okay. I think we spent the last two webinars going over, everything's exploding. We are seeing increases in syphilis. These syphilis can cause some pretty scary stuff. We're seeing it being transmitted to babies. More and more babies are being affected. What can we do? This is, kind of the meat and potatoes of where we wanted to go today. And so, how can we actually kind of reduce transmission and prevent some of these cases? And so, our next section, we're going to be chatting about that. The first thing that we want to discuss is kind of the role of health departments. Um, And again, health departments are there to be as a resource. We're also there as a safety net, oftentimes in different communities. But we alone can't do everything. And really needing the support of health systems, of community health workers who are doing phenomenal work, engaging with individuals, and kind of, again, it takes a whole system to be able to kind of do this. But again, let's start with the health departments. Next slide, please. Often health departments have um, people who are called disease intervention specialists. In English, this is commonly abbreviated as DIS. Um, these are public health professionals who are basically problem solving, negotiating, and communicating with people with certain diseases about how they can reduce the transmission of disease in their community. I think during COVID-19, this got really popular with contact tracing. DIS or disease intervention specialists basically do that sort of contact tracing, but they do so much more than that. Um, they, especially for sexually transmitted infections, we work with providers and help them, stage and treat people appropriately. As Victor described, we're going out there and, making sure people can make these appointments, especially if they're pregnant. They don't have access to transportation and they need to have three scheduled appointments in a row, or they have to restart their treatment. Um, we are, going and finding people to make sure that they're appropriately treated. A lot of it is that sort of investigation. Sometimes it's that case management. We have to follow these people over a period of time. We have to connect them to treatment. This is also for, people with HIV. Um, you know, if we start noticing that there's certain trends or patterns in the folks that we're working with, potentially there might be an outbreak of certain diseases, and needing to kind of, respond to those kind of outbreaks. Oftentimes people are unsure about sexually transmitted infections. So a lot of it is, you know, educating people and counseling them on, how they can prevent future cases or future infections. Um, you know, Often in the field, people don't have access to medical care. So in some jurisdictions and some states, DIS will do testing. Victor has, I've done blood draws in the field because we're licensed to do so in Washington State. Again, follow your state's guidance on that. But um, and again, sometimes if we're out in community and someone is experiencing houselessness or, they have other social determinants of health that need to be addressed, linkage or referral to other systems and services as well. Again, I feel like Victor and I, we have our stories, but just again, kind of the all-encompassing role that DIS do. Next slide. I also think it's important, that DIS look like the community that they're serving. A lot of these conditions, affect a variety of people. And so it is also really empowering that disease intervention specialists look like the community that they're serving as well. Um, this will be for Victor to kind of chat a little bit more about his model of preventing disease transmission in Washington.
Thank you, Ben. So my team's team is named Syndemic Care Connection Team in the state of Washington. Essentially, when we receive a case report for a pregnant person who tests positive for syphilis, we automatically begin reaching out and investigating that case report. We working with the provider and working with the client to ensure that they received adequate treatment per the CDC guidance. in terms of the staging for syphilis. We are also able to engage folks in the care. So if they're needing transportation, if there's a barrier challenge, we're able to assist with that. We excuse me. Also, we support people with or exposed to viral hepatitis, syphilis, HIV, and seeking access and completing or engaging in medical care for these conditions in the Yakima Valley region, as well as the Benton Franklin region here in Washington State. We do a great job in keeping that communication with the local health departments in terms of if we received a case report of someone test positive for syphilis, we're able to work with the local health department to keep that open communication to help monitor the day the individual tests positive, the day we're able to get them treated, and then upon birth. So we're doing some monitoring, ensuring that we work with the providers to test during the third trimester for syphilis for an individual. And also, we offer testing to their partners if they need to be tested in the field. We are licensed to test for HIV and syphilis. Sometimes, locate and sometimes when we're locating folks in the fields, it's not as easy as it seems. If providers aren't able to reach a client, we do work with them if we need to do field visits, do contact, uh, try to do our best to reach that client. If we, we use all available resources given to us in that case report if we need to go out to an encampment or if we, find out that they're hanging out in certain areas, we're able to kind of go out there and spend a little more time on these cases and do more investigation because these are some more challenging cases. But not to say we do have some excellent cases that we work right away, like the previous story I did mention, work together with the provider and the health department. So we connect folks, people living with HIV. We do also are able to provide transportation or kind of figure out with the client what's going on with you. Well, how can we re-engage you if a person living with HIV is out of care? How can we get you back into care? So we're trying to support ongoing medical care for people living with HIV. So there's a lot that our team does within the three counties we do support. But we also support counties around because again, folks do move around. So we do our best to communicate all around. Next slide, please. Let me go ahead and hand it back to Ben.
Thanks, Victor. Yeah, I really appreciate Victor's team. I think kind of a newer model, at least here in Washington State. And they've been doing some really awesome work. So I just wanted to plug them a little bit. And maybe other states could adapt that as well. Um, so another way to kind of reduce transmission is through treatment as prevention. Um, so next slide. So treatment as prevention is basically, um, you know, just treat someone, you know, as soon as they're kind of in your door, if you suspect syphilis. And, some of the logic is, if someone was exposed, especially if they were exposed to someone who had symptoms, they're already in your door. You can get them treated while you await their test results. And that could kind of prevent, if they're also an early case, when they are the most contagious, it could prevent any future cases or infections of syphilis. This also is, oftentimes, if someone has a primary partner or a spouse, one person gets treated while they're waiting for the other partner to get tested for their results. They continue to have sexual contact, and then the first person could get reinfected. And so sometimes you keep passing it back and forth. But if you just treat that partner there, you can kind of prevent that transmission from happening. Um, so treat people who are exposed to syphilis. Um, uh, People who have signs of symptoms of syphilis, um, get them treated just in case, especially if they talk about their sexual history, and if that kind of matches the current epidemiology of syphilis in your area, and they have those kind of telling signs and symptoms, you can treat them while they're waiting for their test results. At the end of the day, you know, um, you can always call them to say discontinue your doxycycline, or you can cancel those future appointments for those 3 doses. This is especially so if you have a patient who's experiencing homelessness. As you know, Victor kind of mentioned, a lot of folks have issues trying to be able to get into appointments or into health systems. If someone is pregnant, again, we want to prevent those congenital cases from happening. And any other individuals who are having difficulty with medical follow-up. Treatment as prevention is a really great way to kind of reduce that transmission. Next slide, please. Another way to kind of prevent transmission is through surveillance, is through routine testing and making sure folks have adequate access to testing services. Next slide. So this is great, especially for community health workers or for other folks in the community to be able to know where folks can go receive testing. And this could be at community health clinics. This can be at, Planned Parenthoods. This could be some syringe exchange programs or syringe service sites, some health departments. And some community organizations also do routine HIV and sexually transmitted infection testing. If you are super confused and you don't really know, where in your community, talk to your local health department. And maybe they have additional resources that you were unaware of. But again, that kind of routine testing and people knowing that their status and knowing if they have syphilis or not is a really great way of preventing transmission. Next slide, please. Another really great strategy to reduce transmission is through education and outreach. And this is really where we lean on the phenomenal work that our community health workers do. Next slide. I think, as a community health worker, the basic things to take away from our couple of webinars is, what are the basic symptoms? So some of these sores, some maybe rash on, body parts where people have sex. Know that it's either, the treatment for it is either a couple of shots of penicillin or maybe some doxycycline pills. So when you're communicating with people, to kind of let them know what the treatment may look like. Like, oh, let's go see a doctor. This could be syphilis. You might get a shot or you might have to take some pills. Um, and then also being able to know where people can get tested, um, especially if they have those signs and symptoms. And then also let them know that, they should be, informing their partners um, that they should also get tested and treated as well. Even that preemptive conversation can be really helpful. Also warning them too that sometimes people from the health department will be calling, such as, Victor and me, disease intervention specialists, where we're there mostly to kind of help out and make sure people are connected to treatment. Next slide, please. And again, I just wanted to reiterate that the strategy to reduce transmission really is a collaboration between health systems, clinics, community health workers, local, state, and tribal health authorities. It takes all of us to kind of work together um, to be able to kind of prevent some of these cases and these infections. And we're appreciative of this collaboration. And hopefully this can spark additional collaboration between all these folks who ultimately just want to make sure people are healthy and safe. Um, so that's my end of my little soapbox. Next slide. I'll pass it on over to Victor for one final story.
Thank you, Ben. In our final story, we wanted to really discuss the services in collaboration with folks. This person presented to the syringe exchange program where they tested positive on a rapid syphilis test. They did not have time to receive or to receive treatment or receive confirmatory testing at the time. They the They did try to connect a person to the local health department for testing and treatment, but unfortunately, the individual did not make it. This is due to the individual who has unstable housing, living in a certain area, uh, on the streets. So for our role, we worked with the local clinics to try to reach out to this person, and ask around if they might have, if a clinic has seen this individual, it with the clinic they were in care with previously. Unfortunately, they had not seen them. We did also do outreach and try to reach out the client to social media. Uh, However, we were not successful. But the one great thing about social media is that we're able to actually investigate someone's social media page, confirm that that is the individual. So it kind of gives us an idea of who they are, what they look like, are they in a relationship? A lot of folks like to post things on social media, and if the profile is public, then this helps us give us some information on who the individual is, what kind of risk factors that they are facing, any kind of known associates that they've been working with, that we have been working with, kind of gives us an idea of who they are. 6 months later, since within that time frame, we were not successful in locating the individual. However, we did have them on our radar. 6 months later, the individual did come back at the local health department to receive treatment for gonorrhea and chlamydia, because they also tested positive for these two other infections, alongside syphilis. They they was able to test for syphilis at the visit, but because they did not have a confirmatory testing, they only tested positive on a rapid test. We were able to now draw their blood and confirm that they did test positive for syphilis. Considering they had a positive rapid, the local health department presumptively treated them for syphilis at the time. Persons most likely, we were considering more likely a latent case because the individual did not recall any signs or symptoms. At this time, upon a conversation with the individual, we did let them know there was an incentive program for pregnancy capable people to complete their syphilis treatment. So on her first dose and being there, we were able to provide her a gift card for her first dose. She also expressed needing assistance to getting to her appointments to her OB care. This is where our staff really came in and was able to help schedule and get her to her appointment at a community health clinic. And when she was going to be picked up, she did mention she did have poor experiences with certain clinics within the area and requested to go elsewhere. Urgently, we scheduled another appointment at another health clinic who was willing to see her that same day. She was able to get her second dose. One thing we do want to let folks know is that people who, in our experience, people who are unstably housed or who consider themselves homeless, uh, have an idea already of where they feel uncomfortable going to a certain location. So we want to be respectful for that. There are some times that we do go along with clients, and take them to their appointment and wait with them in the lobby just to give them that comfortableness and security that they're being seen. We're meeting clients where they're at. Um, on her third dose, we were able to pick her up, take her to the local health department to complete her series, where she was able to receive a gift card for completing her treatment. So with that being said, and with that being said, we're also able to work with her in getting her into OB care, with another local community clinic that she felt most comfortable with. We did follow up with her, just to make sure that the clients are feeling safe and feeling met where they need to be. Just because there are sometimes if the client feels judged or not being heard, they primarily won't go back. So it's our job to figure out how can we engage folks into care and continue to stay into care until upon birth. So this was a really great story all around, working with the local health department to ensure that this client receives adequate treatment for latent stage of syphilis. Next slide. All right. So sorry. So stories from the field. Co-locating testing services at a syringe exchange program, treatment as prevention while waiting for results. In that previous story, because the individual did have a preliminary rapid syphilis test, although didn't have anything to confirm, she was willing to get treated the same day she got tested for a confirmatory test. Field service staff working with patients by providing financial incentives and providing transportation. Our job is to really connect folks to care, meeting them where they need to be at, and ensuring that they understand the challenges and barriers that they will be facing if they do not get adequately treated. Working with community health clinics, being flexible with vulnerable patients, having conversations with clients, and really understanding where they feel more comfortable with and how can we work with that community health clinic. We've been really receptive from these community health clinics because we're able to introduce ourselves. Of course, we are from the Department of Health, but we also just let the community health clinics know that, hey, we're here to help support you, the health department, and the client. How can we best support you all? Um, excuse me, working with health department allocating treatment for clinics and also willing to treat patients. So if a provider is unable to have the bicyclin injection, we are able to provide that to them and be able to ensure that the clients get adequately treated. We also want to make sure that there's a clear communication between everybody, that everybody's on the same page, everybody's aware of what the client needs, the provider needs, and where we can go from there. We also, in having these conversations, we need to be, we see the need for compassionate and trauma-informed care. We want to make sure that we are able to communicate with clients, build that confidentiality, and ensure that we're here to support them. Nobody's in trouble. How can we work together? This is an example of collaborative effort it took to support one person's health. Next slide, please. I'm gonna go ahead and hand it back to Ben.
Thanks, Victor. Yeah, again, I really appreciate that story. I feel like it synthesized a lot of our kind of strategies on how we can reduce transmission, really highlighted the interconnectedness of all these systems and how we can kind of support one another. Again, it takes a whole system to prevent disease transmission, so that we can reduce the number of people who are affected by syphilis. Um, you know, public health we need the support of these systems to reduce the barriers of accessing care for vulnerable populations. Oftentimes, um, you see a patient arrive at your door for treatment or testing, um, but there was an insurmountable level of work that was done to get that patient there. So really kind of being mindful of that. Um, I think some of the stories that Victor shared, especially last session, there are so many things going on for a lot of our most vulnerable individuals. Um, so yeah, kind of again needing that kind of support to understand and practice compassionate care and meeting patients where they're at. Um, Really is, I think, how we can kind of reverse the trend for some of these things that we're seeing. Next slide. Jane, you're muted.
Thank you for that. Thank you to our wonderful speakers for this wonderful presentation. We are going to enter our Q&A portion. I've been monitoring the Q&A function on Zoom, so we have a bank of questions for our lovely experts. And also, I do want to extend Renee, if you also feel comfortable, you're also an expert. You did do the first session as well. Go ahead and jump in where y'all see fit. Our first question is from Alex. They are wondering, they have read that secondary syphilis is contagious, but they've heard from different providers that it's not contagious if it is not an open sore rash. Which statement is more reliable?
Yeah, I could feel this one, and if anyone has more of a clinical background, feel free to also chime in. Um, I would agree that the most contagious a person is when they do have those open sores. Um, but that is to say that it would be false to say that they are not contagious at that stage. I think when it's like a relative, like compared to someone with no symptoms, they are more contagious. Compared to someone with a sore, they are less contagious. But still, kind of our guidance and kind of what we see is that if someone is in that primary and secondary stage, they are the most contagious and where they can spread syphilis with the most frequency. So that those are the cases that we want to prioritize and make sure that they're adequately treated to kind of prevent that future transmission.
Awesome. Does any other person want to follow up with that? Great. Thank you, Ben. We have another question. If a child was born with congenital syphilis and they are RPR, convert back to non-reactive, uh, would their TREP remain reactive? Sorry, that was tough. Um, yeah, so is their TREP or would they remain reactive? I think is the question.
Yeah, I can also take this one. Great question. It honestly depends on the child's immune response. And I think you could see um, that RPR test converting to non-reactive over time. We see that in adults. The TPPA or the treponemal tests could come back reactive, and then over time, again, especially after cautionary treatment, could go back to being non-reactive. Um, so I think it's there is no like black or white answer to that. It's like, yeah, it could happen. Um, and what I think is important is that a health department will have that history for that child. So, should they become a sexually active person later on in life and they are responsible and they're getting routine testing because they are sexually active, and we have that testing history to know, oh, um, they do have now a reactive test. Is this a new case, or is this, their old congenital case? Um, so again, we would have those kind of data points to make sure uh, in the future.
Thank you, Ben. This is a two-part question. I'm gonna offer the first part. If a patient has a presumptive diagnosis based on a positive TPA and risk factors, but never has a positive RPR, how do you follow them after treatment?
I could also take this one.
Job,
This
Ben.
has been this is really hard. So I think this kind of falls under the when in doubt, treat a patient. Um, oftentimes if someone is so early in their infection, they may not have an RPR. They could pop a TPPA, they could have a reactive EIA. Um, and especially if they have those signs and symptoms, if they have a chancre, they may not have an RPR. So they would have primary syphilis, so treat them. If someone is pregnant, out of caution, treat them. Um, the what's confusing is based off of uh, definitions and standards created um, both by local health departments and by CSTE, which is the Council for State and Territorial Epidemiologists. Basically, a bunch of the nerds that come up with these definitions, um, that person may not have a case of syphilis, but you, as a provider, as a healthcare professional, can take on these further judgment calls on whether someone should be treated or not. And this is now Ben's opinion and not medical professional, treat them out of caution. But again, you as a provider, you can consult with other clinicians to determine if that is necessary. I hope that answered your question or that first part.
Thank you, Ben. The follow-up, Renee, did you want to get in there? I don't know if I saw you come off mute.
No, I'm not going to add to that.
The follow-up to that question is how do you follow the infant?
Yeah. There is again so much information in my brain, but then sometimes it it doesn't stick in there. So I'm trying to look up the exact testing interval, but basically, so if you have a child who either the mother had syphilis, and if they did or did not have congenital syphilis, but they had a positive syphilis test, um, during those kind of uh, follow-up appointments with a provider, this is a time when babies have to, have immunization schedules and all those kind of follow-up appointments with the OB and with the pediatrician. During those same intervals, you can continue to test the child to continue to first observe, did treatment work? Are they kind of observing anything? And then kind of having, that sort of testing history and evaluation and follow-up. So ideally, that should be done during follow-up visits with the pediatrician and OB.
Thank you, Ben. We have a question asking if there are any resources on expert lectures or presenters to cover these very clinical terms of these diseases for nonprofits. So thinking about maybe more layman's terms, if you will, resources out there, if anybody knows. Let's come back to this. We're gonna look into it and we'll add it to the email if slash when we find resources for this, but I will make a note of it for as part of my homework. Moving on, is there any concern for syphilis becoming a resistant bacteria with folks that may get many treatments?
I could take this. Um, it's kind of a gag. It's kind of uh I'm trying to professionalize what I just said. It's kind of wild how syphilis is still treated with penicillin. Not many other infections are appropriately treated with penicillin. So many other bacterium have developed resistance. We have been treating with penicillin since it was first discovered in like the 40s, 30s. Uh, and so we have not noticed any sort of treatment failure with the specific bacterium. And so, at this time, I this hasn't been a concern, and it's certainly something that we're continuing to observe and monitor. Different states monitor for different antibiotic resistant strains of diseases. But this is just something that we're not observing with syphilis, which is really weird, when we see other kind of infections and conditions.
May I add in just a little too? We do get some clients every now and then when we're part of our investigation, they say that the treatment doesn't work. I've got it again. I'm symptomatic. But then, upon investigating them, we talk about partners and the importance of their partners getting tested and treated. Because if their partners don't get treated and they have sex with them again, there's the possibility of reinfection. So a lot of times folks say, "Oh, it didn't work. I know it doesn't work." So actually, did your partner get treated or tested? And a lot of times they're like, "Well, no." So how can we best support you from getting reinfected? Let's get them tested and treated, and let's get them in available resources. So a lot of times clients we have heard them say it doesn't work. Actually, according to from what we do know is if we're digging into the investigation, getting their partner tested and treated, then the reinfection stops. And I know sometimes some clients say, "Oh, it worked this time." It's like, well, because your partner got tested and treated. But that's a great thing. That's great, but continue to get retested.
Thank you so much, Victor. Renee, anything? Thought I saw a twitch.
Yeah, I just would like to say, in part, I think it also is the work that health departments do to find people and find their partners. This doesn't happen with gonorrhea or some other conditions.
Thank you.
And so I think that's part of why drug resistance hasn't developed so far.
Look at our experts. Moving over to the chat really quickly, we have a question. Does a different type of TREP specific test, such as FTA, oh, maybe it's just a comment, do a different type of TREP specific test, such as an FTA? That was my misunderstanding. Going back to the questions, why do you all, why is there not a lot of focus on pregnant females who have GC/CT infections? It seems as if it's more of a target on pregnant female with syphilis infections.
Yeah, I can start my response, and if anyone else wants to comment. Um, so I think the focus is really there's not enough resources to be able to do that work. Um, Chlamydia, um, well, before COVID, was the most commonly reported disease in the United States. And then it was followed by gonorrhea. And the amount of follow-up and work needed to kind of prevent those cases, we would need more support and staffing. Um, there's also um, you know, the treatment for chlamydia and for gonorrhea is also a little less intensive than syphilis, meaning, they have to take certain doses over a period of time. While for chlamydia, expedited partner therapy or EPT in the commonly used letters in English, um, is able to be used. So, for example, if you are a pregnant person with chlamydia, you are given, I think, a couple pills of azithromycin, or especially not doxycycline because you're pregnant, you can't take doxy. You can give your partner those pills to kind of prevent transmission. Um, it's also oftentimes at delivery. Um, I think babies are given antibiotic eye drops because they're worried about like ocular gonorrhea. And so these are things that are just kind of routinely done, as opposed to kind of syphilis, which needs more of that kind of workup and less, I would say, readily available interventions. That's kind of my thought process and explanation, but others feel free to also chime in as well.
Anyone else? Okay.
Uh,
Uh, sorry,
Sorry.
go ahead, Victor.
If someone does have co-infection with syphilis, with gonorrhea or chlamydia, we do recommend to the provider that they retest them again for a test to cure, just to make sure that they're being followed up and making sure that there's no reinfection of the gonorrhea or chlamydia.
Thank you, Victor. And in being time conscious, we have about 5 minutes left. I have one question I think we should end on because I think it's all interconnected. How would a disease infection is specialist, investigation specialist, why am I forgetting? Deal with domestic abuse when a pregnant female refused to provide the partner's name but lives with the partner. So thinking about all the ways screenings touch.
I don't know the answer to this. I think it's complicated and um, DIS will do the best they can and try to work around and find support for the person. But it it's going to depend on the circumstances.
Thank you, Renee. Anybody else want to add to that?
Um, yeah, to also add to that, again, you can't make everyone participate in this process. I think there's a lot of mistrust in um, governmental entities. I think public health has caused a lot of harm on certain communities and individuals. And so sometimes people are just not going to want to talk to you or participate in, the DIS, the disease intervention process. And so that's really, you do what you can. You support that person who's pregnant to be like, here's all the information. Here's where your partner can go. I understand you're not comfortable with providing me any information. Here's how you can prevent reinfection. Again, this is really important for the health of your baby and kind of framing it in that way. Another opportunity too is to leverage working with the medical provider as well. And just saying, hey, this patient does have a partner. If they're in the room during their next visit for their next treatment, for their next dose of bicillin, maybe have a conversation and maybe get them connected to testing and treatment. So maybe it wouldn't happen at the public health governmental level, but maybe more on community health clinics and the medical provider. But it's difficult. It's difficult. It's a really tough situation.
I would say in this line of work, it's we do see these cases a lot. The hard part is we don't assume. We try to work with the client, and sometimes if the client doesn't is a little resistant, we try to earn their trust to be like, well, what can we help support you today? And we work with them through that conversation to earn their trust. And then at some point they're able to have conversations. Well, I can, introduce you to my partner. And then you can offer testing them if they're willing to. So a lot of the times it's really we do have that a job of ensuring we're working with our client. Right? But in order to talk about other partners, sometimes it just takes some time to not focus on your infection. Let's focus on how are you doing? Do really like in the earlier slide, be compassionate. If their partner is in the room with them, kind of find ways to kind of separate them. Hey, we're both here, but we do want to have conversation with her, with him. But it all takes up time. And a lot of times when this line of work, when people think, boom, we can get them tested, we can get them treated, boom, 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 boom. A lot of times it's, well, it may take a full day, it may take a full week working with these clients, but it's the time you invest to ensure that these clients understand the risk factors. And if the individual does report having domestic violence, we have that available resource on hand right away. Here's a number you can contact. Here's the on a local level, on a state level. Here's a number, but we can also, give that information to that individual secretly when we have both of them apart. So we just want to just rebuild the trust with the clients. We understand that it's not always going to be easy, but we also have to tone a voice how to work with them. So it's just something that takes some time. We do want, as professionals, we want to get this done over with, but a lot of times it's like, I'm going to be working with them all day today. Great. I will work with them in 2 days, take the partner to get tested. It takes time. So a lot of investment in the time of work that we do is it takes a long period of time.
Thank you so much, Victor. Thank you, everybody, to our wonderful partners at MCN. Thank you so much to our wonderful speakers with the Washington State Department of Health. That is time. We are done for today. I would love to give a huge shout out and huge recognition to our interpreters with Language Access Austin. They are fantastic. If you do have further questions and want to get a hold of us, our contact is on the screen. Resources, recordings will go out from part 1 and part 2 within the week. And we hope to see you all soon. But thank you all so much for your time. Thank you all so much for coming.